On this episode of MedSurg Moments,
there are a couple of very special people we'd like to introduce you to. Our two new co-hosts, Kellye and Marcela.
My name is Kellye, and I have been a bedside medical surgical nurse for about 11 years. My love for nursing started very, very young. I was probably in elementary school, and I remember my grandfather, he took sick.
I was born to two teenagers on the south side of Chicago who were not done with high school yet and said yes to being my parent. But the drive to work and listening to you all chat about the things I deal with every day, it really sucked me back in.
Our topic today is how to care for stroke patients.
So this was an interesting fact about stroke patients from the Cleveland Clinic. Only about 30% of people in the United States know one or two.
I feel like one of the biggest things that is really important is the patient education component of it.
When I was a new nurse, I was very intimidated by the level of disability and not fully understanding what the possibilities were for them in the future, like the prognosis. And what I learned is just...
And then when they come out, the doctor has to be there and the doctor has to initiate.
Oh, so the nurse can't initiate.
Well, I did.
This is Mary Chance.
Sam.
Eric.
Marcela.
Kellye.
And Sydney. Welcome to MedSurg Moments, the AMSN podcast.
This podcast is an engaging look at the lives of and surrounding medical surgical nurses.
We're proud MedSurg nurses just like you, sharing our stories, insights, and experiences to support you in your nursing journey.
Our topic today is how to care for stroke patients. But before we get started, there are a couple of very special people we'd like to introduce you to. Our two new co-hosts, Kellye and Marcela. We're so excited to have you both on board and would like to take a few minutes to let you share your story.
My name is Kellye, and I have been a bedside medical surgical nurse for about 11 years. My love for nursing started very, very young. I was probably in elementary school, and I remember my grandfather, he took sick, and I just always seen ladies in white, and I was wondering, who are these ladies in white? They would come in and out of my grandfather's room. My mother and my grandmother would always treat them nice, would always have questions for them. They would always bring me candy. Later, when I grew up, I understood that they were nurses. The nurses were the ladies in white. So as I began to get older after my grandfather passed, I was always interested in doing things in the hospital. When I was in middle school, I served as a candy striper. In high school, I did a dual certification where I obtained my CNA license, as well as graduating from high school through the career school program at my small town in South Carolina. I worked as a CNA through college. I later obtained my LPN. I worked 2 years in an assisted living facility. That's where I gained a lot of my clinical skills at the bedside as an LPN. And then through there, I stayed working as an LPN through my RN associate's degree program. And during that time, my husband found me. We got married. We moved to North Carolina. I later worked on my BSN degree as an RN online. And then he took a new position and relocated us to here in Atlanta, Georgia. I now work a med-surg unit. It's called the Dedication Education Unit, where we primarily have nursing students from all over. We have colleges and universities where we serve as their clinical instructors. And I also obtained my MSN and nurse educator degree just last year. My passion grew for just being a nurse educator in the med-surg unit. And 5 years later, 2 kids later, I'm still that supportive bedside nurse and nurse educator. Outside of work, my hobbies are just skating. I love to go bowling with my family. I love traveling. I've been very, very intentional on this new journey of me working out. I pride myself in doing 2 to 3 days a week working out. I'm really interested in the wellness journey as I'm being a nurse and caring for others and being a mom and a wife and all those things. So I'm really excited about that. And I'm excited about this journey as an AMSN podcast co-host.
I was born to two teenagers on the south side of Chicago who were not done with high school yet and said yes to being my parents. They had no business being the best parents ever, and they were indeed my best friends until I met my husband. I had no experience with the medical field. I was not exposed to any kind of medical situation. As a kid, I loved art. I loved singing, performing, making my classmates laugh. Even through high school, I was that kid that teachers said, she's so bright, but she's not meeting her full potential. Part of me was really okay with that. I graduated just barely, and still somehow I made it into Marquette University. I was absolutely not ready for that. I did one semester there and I ended up withdrawing. Art was not something that I really wanted to do in a career. I left, ended up moving in with my now husband, had my first daughter at 19. I was young, it was frightening, but also I was so excited for this experience. Motherhood and birthing were this whole new obsession that I had, and those nurses were my first experience into the field. I don't know how I landed on nursing. It really just had to be my birthing nurses that inspired me. So I did choose nursing, and my nursing school experience was traumatic in the sense that I was still not good at school. It did take me 5 years, I'll be honest. I had the young daughter, so I did part-time prereqs in the city colleges. And then I went on to join a nursing program with Chamberlain. Struggled once again, but with the help of my family, the help of my grandmother's candle-lit prayers. Truly, she lit a whole array of candles and she told me that she would be praying for me. And I did it, and I finished nursing school. I was hired onto a pulmonary step-down, and I worked for 3 years there. The way I ended up in med-surg, it was COVID. I actually transferred to the COVID unit despite being pregnant. I was going into the COVID units when people were trying to get out. But the truth is that the acuity was such that you could be guaranteed sometimes only 2 patients. And at that time, I was like, oh yeah, that sounds great. About a year later, they told us, okay, we're going to be reverting back to med-surg. It was chaos, but it was incredible, the teamwork that I started witnessing. I stayed in med-surg. I didn't leave. I had 3 kids kind of back to back. They are 1, 3, and 5 right now. And really, this past year has been a struggle with being in love with med-surg. And that's why I like to say that right now I'm on a journey to reignite my passion. And I just happened to start listening to this podcast, and it really sucked me back in. The drive to work, sometimes I didn't want to go, I just wanted to be home with my kids. But the drive to work and listening to you all chat about the things I deal with every day, this was now conversations together, even though you guys didn't know I was there. I am so happy to be here with everyone. And I am so excited to continue these conversations and be that person for the people driving to work.
Wow, thank you so much, Kellye and Marcela. We often talk about the journey once you're in nursing. It can go so many different ways. Bedside, education, leadership, all these things, but we don't often talk as much about the journey to get to nursing. And you both have such incredible stories and completely different journeys compared to Eric, myself, Sydney, and Marites, our other co-hosts. So I think that's so fascinating to listen to, and you both have such great stories. So why don't we go ahead and move into our topic? We are going to talk today about how to care for stroke patients. Is there anybody who'd like to get the conversation started?
Has anyone worked specifically on a stroke unit? I don't have a ton of experience with stroke patients. I was on a COVID unit, cardiac unit, and then multi-service where we didn't really have the acuity to take care of stroke patients.
I can kick us off for sure. I've been in a nursing education role for almost 5 years now, but my first 4 years of nursing practice I spent on an ortho neuro unit. So it was kind of interesting because it was mostly surgical, but then we had the stroke patients as well. It's a really, I don't want to say scary patient population, but I think neuro can be a bit intimidating sometimes. I know I definitely felt that way, especially as a newer nurse. I always heard these stories of heroic assessment findings. Somebody found like the tiniest little change and their ischemic stroke converted to hemorrhagic, and we got them to CT and we got them to surgery and we saved their life, all these things. And I was like, how am I ever going to pick up on these tiny little things? But as the years went on, I really got a lot more comfortable in my practice in those ways and my neuro assessments and NIH stroke scale. The organization that I work at too, we had been making a lot of strides towards becoming like a stroke certified organization. There was a lot of energy, education, a stroke coordinator trying to help us learn a lot of those things too. So there's so many things we could talk about with stroke patients, but I feel like one of the biggest things that is really important is the patient education component of it. There's a lot of different things that can cause strokes, whether it's blood pressure related, if it's AFib related, head injuries. Maybe they're on blood thinners for some reason and they took way too many and it was super therapeutic. They had to bleed, so many different things. So there's just a lot of education that can go into it, and especially the monitoring afterwards, like how you can recognize stroke symptoms again, what things you need to do to be managing your other conditions to help reduce your risk of a stroke later on. So lots of really important stuff like that, diet changes, all sorts of different things.
Being an educator on my unit, we work with med-surg patients. In the populations we're starting to see are more stroke patients. So I had a patient, and I always call my older population young ladies or, things like that to make them feel good about themselves. But she was taking down her Christmas lights, and her husband was outside. She got on a ladder, and as she was going up the ladder, she just fell off the ladder and she just fell to the ground. And her story coming into the hospital was she blanked out. And as she was on the ground, it was her granddaughter that was looking from the window and seeing that she couldn't get herself up. And the husband was like trying to pull her up, and she was talking and her speech was very slurred. So the granddaughter heard through the window. She immediately called 911, got her grandmother to the hospital in a timely manner, and they administered the TPA. They got her to my unit. We had to automatically do the CTs, the MRIs, get them onto the unit and have our nurses educate with the NIH scale. It was the time component that saved her life. So that patient education on educating the families and educating the patients about the signs and symptoms for stroke, that saved her life.
I agree with both of you guys. There's a lot to it. And you're right, Sam, you can go on about so much about the stroke patient. I had personal experience, life experience, like right before I started school with this occurring in the family. And right after it happened, I kind of went into nursing, and you can kind of see, you're like, oh, I wish I would have known this. I wish I would have known that. It's really traumatic for them emotionally. I mean, people bounce back, people recover, but some people, when you wake up and it's just a new way of life, the weakness, dangers of swallowing, speech, you have to be there emotionally for them.
So this was an interesting fact about stroke patients from the Cleveland Clinic. Only about 30% of people in the United States know one or two signs of how to recognize a stroke, just one or two symptoms. So that was kind of scary.
That's a crazy number because it really is the most important part is recognizing when it's happening. And then the timeline for treatment starts right there. The clock starts ticking. So if you're outside of a hospital, it's so great that that family member saw through that window because then they can also tell the hospital it happened at this time. And then they can either figure out if it's a hemorrhagic bleeding type stroke or if it's a blood clot type stroke. And if it's the blood clot, you want to get that TPA. I believe it's within a couple hours. I know the hospital timeline is trying to push treatment as soon as they're in the door from that moment to treatment under an hour is the goal. But at the bedside, I think crucial is the bedside report because at the bedside, we're the ones that are supposed to recognize it and start that clock. And sometimes we meet our patients at the start of the shift, 6 people, we don't know what they looked like an hour ago. So if our nurse isn't telling us at the bedside, hey, she was alert and oriented times 4, she was moving around completely normally an hour ago. If we get there and we don't know that, and we think that she's usually slurred speech or she's usually weak on the left side, we wouldn't even recognize that this is a stroke situation where we can start moving to get them treatment as soon as possible.
That actually happened to me one time, Marcela. I got report, said that she was fine. I went into the room and she was not making sense, a little confused, kind of weak. And we called it and we caught it.
Awesome.
It's scary, you know?
Does everyone's facilities have specific code stroke teams?
Yeah. They call it hot stroke at our facility. And they're so specific. Only certain people can call a hot stroke. We have to call the rapid response. And then when they come out, the doctor has to be there and the doctor has to initiate.
Oh, so the nurse can't initiate.
Well, I did. Because you just knew something was wrong. Well, I know. You know what's so funny? It's because when it happened, someone said, oh, no, she's just like that. She just acts crazy sometimes. And I said, no, it seemed off, even though you just met him. And I said, well, okay, we'll call a rapid. I'm like, okay, it's not rapid enough. Let's just call a stroke. And I'm like, what's the worst that can happen? You know what I mean? We're union. And it turned out, I mean, she had a stroke. They caught it. She's okay.
It's so easy to disregard certain symptoms for nurses sometimes because, oh, it's an elderly population. They have been immobile. This is normal for them. Like you also said, it's an emotional thing. People who have had a stroke, if you don't assess what their normal is or what their new normal is, and you're just treating them like, okay, you're just disabled, you're nonverbal. I think in the hustle bustle of being so busy on a shift, it's easy to move past a patient. A patient sometimes is completely alert and oriented, but has slurred speech because they have a history of a stroke. So when they're disregarded by staff, people walk past them and don't ask them questions about how they're feeling or what they need. And they think it's just not an oriented person. And they come in and they do things in the room without verbalizing what they're doing or grab equipment and then just leave. Sometimes I'll meet that patient and try to have a conversation with them. And then they're able to express, sometimes people just don't even look at me when they come in here. And it might be completely new for them, this state of being where after a stroke, the damage has been done, where they can't move one side of their face or they can't swallow anymore. And that's new too. So when you're doing your bedside assessment and this person has a new stroke, that swallow study is so important. The patient might think they can still swallow pills. They might say, oh, I swallow pills all the time. Well, you're now here after a stroke event. We're going to have to assess that because you might not even realize that you're healing from some damage or have some permanent damage to your swallow that we don't even realize.
Yeah, Marcela, that's a great point, is assessing where their deficits are and involving your ancillary staff like PT, OT, that swallow study, and setting expectations of their new normal and helping them find that, helping them discover what they can do and what adjustments need to be made to get them home safely after that stroke event.
When I was a new nurse, I was very intimidated by the level of disability and not fully understanding what the possibilities were for them in the future, like the prognosis. And what I learned is just talk to your patient, interview your patient, have a conversation with them. And like you said, PTOT, I had to start asking them, what is the trajectory for a patient like this? How possible is it for them to be walking again or be talking again? Because right now their life is flipped upside down and they can't do those things that they used to do.
Yeah, we definitely discharged a lot of these patients to a local acute rehab facility where they're doing upwards of 3+ hours of therapy a day between PT, OT, and ST. So the effects of a stroke can be truly devastating. I have some stuff pulled up here from the CDC actually, and says that stroke is the leading cause of serious long-term disability. So for some people, they might not get a lot of function back. And then there's others who can. And it's really hard, I think, to tell what's going to happen. But I think we hit the nail on the head a bit that the fast recognition and treatment is really the best tools that we have for these patients who are experiencing some kind of stroke.
So when it's recognized that the patient is having a stroke, first we have to figure out for sure, is it hemorrhagic or is it a blood clot? Because if it's a blood clot, you want to get that TPA, and that's the tissue plasminogen activator. It goes through the vein. That treatment breaks up the blood clot, and you want to get that ASAP because that'll minimize the damage done. So if it's after, for example, 10, 20 hours, it's not going to have the effect on the damage that's done to the areas of your body that are not getting the blood flow that they need. And then on the other hand, if it's hemorrhagic, you absolutely do not want to get TPA because I think a complication of TPA is bleeding. So I think they want to get the imaging done from door to imaging within 20 minutes is my understanding. They want a neuro assessment and a CT within 20 minutes of the patient getting to the hospital.
So let's talk about some other things that a med-surg nurse might expect or anticipate in caring for a patient who has experienced a stroke. I think one of the most important ones that comes to mind are your blood pressure parameters. Most of these patients are going to be experiencing some level of hypertension or high blood pressure. Ideally, you should have some sort of order by the provider if it exceeds some level. And there's also specific parameters if they did receive some sort of clot buster like TPA. So knowing what your blood pressure parameters are and then what medications you have in your PRN arsenal to help control their blood pressure as well. Also, we'll expect to do some sort of nursing swallow screen on these patients. I know there's a few different ones out there. I know at my organization, we're using the Yale swallow screen, which is new to us in the last year, which has been really great. Just doing a quick screen on their swallows, see if they need any more evaluation from speech language pathologists, or maybe they're going to head down the road of a small bore feeding tube or something like that. Could be temporary. They may end up in more of a permanent feeding tube situation. But again, it kind of takes some time for the acute effects of the stroke to kind of tone down a little bit and then kind of reassess where we're at and see how much we can rehab for their swallow. You should also expect that they should get some sort of echocardiogram to look at the heart. My understanding is that this is usually done to see if there's anything going on in the heart that could have caused their stroke. So is there a PFO, a patent foramen ovale? Is there a hole in the heart that's causing a clot? Are they an AFib, something like that? And these patients should also be on telemetry monitoring just to see if their heart's doing any sort of wonky rhythms that we might not have known about that would cause their stroke as well. Anything else that nurses can anticipate for the patients?
Preventative nursing care. When someone's not able to move, we got to turn them. That's new for them. How about those contractures? Just about preserving their life pre-stroke.
And oral care is a big one too.
Especially
if they are NPO and have a feeding tube or something like that.
Like Marcela was talking about, pocketed meds, pocketed food. That's all new. That's new for them, or hopefully a temporary new way of life.
Exactly. And I'm going to just chime in a little bit of self-management as well, like helping them understand the way they take their medications, how to exercise, how to just stay on top of their diet, and educate their caregivers if they have family members in the home, how to recognize using the BFAST, how to recognize symptoms of stroke, to let them know that time is crucial. That's critical. Time to getting them to the hospital.
Yes, absolutely. Well, we are just about out of time. This has been a really great discussion about caring for patients who have experienced a stroke. Before we close out, we're actually going to go around and have everybody share one thing that you would take away from this episode.
I would take away when Marcela shared about the timing with the TPA, making sure that when they are at the hospital getting that medication in a timely manner. Some nurses take their time and they don't really understand how crucial that time is. Very important, getting that TPA as quick as possible.
My takeaway is just a little more broad. Everyone has a different perspective and a different view on it, just to see it from other points of view.
I think for me, it's establishing that baseline, how important bedside report is, or at least when you come in for your shift, talking to that patient and seeing how they were right from the beginning, so that when you are busy and an hour to 3 hours go by and all of a sudden they're not acting the way they were when you started, you can identify those symptoms.
Kellye, that story of a family member recognizing that. As a nurse, I go home and I don't share everything I know because who wants to hear all that? But some of these things are so important for our family members to be aware of. And then I think that be fast, I'm going to share that more with people for sure.
Yeah, I think along the same lines, I think the gaps in knowledge in the community is definitely a big takeaway for me. So similarly, just trying to share that in whatever kind of avenues we can with our own families, friends, or whoever else we may be in contact with that would need to know that, I think was a key takeaway for me. Well, Kellye and Marcela, you survived your first episode as co-hosts. How was it?
Wow, it was great. Thank you all for making it a little more comfortable. I was kind of shaking at first, voice a little shaky, but y'all made it really great. So it was awesome. Excited.
This experience is definitely surreal, but I am so excited. Thank you so much, everyone, for having us.
To our listeners, thank you for joining us. We will see you next time.
We look forward to connecting with you on the next episode of MedSurg Moments, the AMSN podcast.
In the meantime, we encourage you to subscribe to MedSurg Moments wherever you listen to podcasts.
To reach us, use hashtag MedSurgMoments on your social posts.
Or send us an email at amsnpod@amsn.org. That's amsnpod@amsn.org.
We are all AMSN members, and if you love MedSurg Moments, we invite you to become a member of AMSN. You can learn more at www.amsn.org.
Finally, the content within the MedSurg Moments podcast represent the views, thoughts, and opinions of the co-hosts and may not necessarily reflect the views, thoughts, and opinions of the Academy of Medical Surgical Nurses.
Until next time, this is Eric,
Mary Tess,
Sam,
Kellye,
Marcela,
And Sydney. And always remember, MedSurg Moments is a moment in our lives and a moment in our MedSurg careers that makes a huge difference.